This is Dr. Hessel recording the podcast on pulmonary artery catheter part 2 for the PGY2 residents on the CT anesthesia rotation. I will discuss the information provided by PA catheters, review outcome data, identify indications for using PA catheters, and leads with some conclusions and recommendations. The reading assignments we have already mentioned previously. So first we'll talk about the information provided. These are summarized on this slide, and I have underlined those that are uniquely available from pulmonary artery catheters. This slide I've summarized the normal values for these pressures. What is surprising to many initiates is that they are fairly low normally. You're all familiar with central venous pressure, so we won't comment further. While the catheter is in the right ventricle, you should pay attention to both the systolic and the diastolic pressure. The systolic pressure can be a sign of either increased pulmonary artery pressure or a right ventricular outflow tract obstruction. The diastolic pressure provides an important clue to evidence of right ventricular dysfunction. One of the most important pressures available from the PA catheter is the pressures in the pulmonary artery, in particular the mean pressure, the diastolic, and the wedge pressure. The mean pressure normally is between 9 and 19, but the accepted definition of pulmonary hypertension is a mean of 25 or greater. When it's elevated, you must consider the hemodynamic causes, which are either increased blood flow, increased resistance, or increased pulmonary venous pressure, i.e. left atrial pressure. The pulmonary artery diastolic pressure is an underappreciated, underutilized parameter. It is normally about 8, and the upper limit is about 13 to 15. The benefits is that it normally approximates the left atrial pressure. The left atrial pressure can never be higher than the pulmonary diastolic pressure, and therefore if the pulmonary diastolic pressure is normal or low, one can be certain that the left atrial pressure is normal or low, and therefore there's no reason to obtain a wedge pressure. However, beware in the spontaneous breathing patient that there can be anomalous low diastolic pressure during inspiration. The pulmonary artery occlusion pressure, also called the wedge pressure or the pulmonary capillary pressure, is the real reason that Swan and Ganz introduced their catheter. Prior to that time, clinicians assumed that the CVP was a good measure of left atrial pressure, but subsequently it is well known that that is no longer true. The balloon, when the balloon is occluding a pulmonary artery, the distal pressure falls until it equilibrates with the left atrium, and thus you have, if you will, a water manometer that allows you to measure the pressure in the left atrium. So why are we interested in the pulmonary artery pressure? Because it estimates the left atrial pressure. And there are a number of reasons why we are interested in left atrial pressure, which are summarized on these slides. To evaluate LV function, which is why Swan and Ganz introduced it for the management of acute myocardial infarctions. It can help detect myocardial ischemia and warn of impending pulmonary edema. It can explain the pathophysiology of pulmonary edema. distinguishing that due to elevated left atrial pressure versus that due to that associated with normal left atrial pressure, in other words, permeability pulmonary edema. It can help detect mitral valve dysfunction. Is essential to define the hemodynamic cause of pulmonary hypertension. Thus, whenever the pulmonary artery mean pressure is elevated to 25 millimeters or more, the patient has pulmonary hypertension, and one must then obtain a wedge pressure to determine the hemodynamic explanation of the pulmonary hypertension, since this gives you a clue to the etiology and also guides the proper therapy of the pulmonary hypertension. Unfortunately, one of the reasons that many clinicians used the pulmonary artery catheter was to evaluate intravascular volume, assuming that the pulmonary artery occlusion pressure was a good clue to filling of the left ventricle. However, this turns out to be rarely valid and has been one of the most important causes of misinterpretation and misuse of the pulmonary artery catheter. The problem is that by left ventricular preload, we mean end diastolic volume. And when we use the pulmonary artery occlusion pressure to estimate left ventricular end diastolic volume, we are making three assumptions as summarized on this slide. Unfortunately, these may not be true. The first assumption, while usually true, can be wrong as summarized here, as is the case with the second assumption, which of course is invalid in the presence of mitral valve disease. But the third assumption is the weakest, because it assumes that end diastolic pressure predicts end diastolic volume. The problem is that end diastolic volume is influenced not only by the pressure inside the ventricle, which we measure by the wedge pressure, but also the pressure outside the ventricle, and most importantly, influenced by myocardial compliance. Thus, there are three factors that influence filling, and we are only measuring one of the factors. The pericardial pressure may not be normal, and therefore we can misinterpret the implications of the wedge pressure. More importantly, the myocardial compliance can be altered. This can be due to chronic changes or acute changes. Thus, it should not be surprising to you that in critically ill patients, often the pulmonary artery occlusion pressure does not reliably reflect left ventricular end diastolic volume, nor do changes in pulmonary artery occlusion pressure reliably reflect changes in left ventricular end diastolic volume. What is disappointing is that this has been known but commonly ignored for the last 25 years. So why is it that pulmonary artery occlusion pressure is not a good guide to intravascular volume? It is because, as we've just briefly mentioned, it is because there are other factors that influence pulmonary artery occlusion pressure besides intravascular volume. And these are summarized on this slide. However, just because pulmonary artery occlusion pressure is not a good gauge of fluid status, it is still an important parameter to monitor because it provides important information regarding LV function, mitral valve function, the risk of pulmonary edema, the pathophysiology of pulmonary edema, and the pathophysiology of pulmonary artery hypertension. Therefore, it must be monitored and measured accurately. One important factor is which phase of respiration should it be measured in. And the convention is that it should be recorded at end expiration, the time when the pleural pressure is normal. During spontaneous breathing, this is usually the higher pressure, and during controlled breathing, it is usually the lower pressure during controlled ventilation, as illustrated on this figure. Another issue is the zero reference point. Unfortunately, this is a matter of some controversy, but the traditional method we still use, which is the phlebistostatic axis or the fourth intercostal space in the mid-axillary line. However, others may recommend other reference points. The key is that one should be consistent, and that it should be consistent between one practitioner and another in a given institution. So, when the pulmonary artery occlusion pressure is elevated, one should try to figure out what the cause of this is. And the first thing is to rule out a false high due to either incomplete wedging, over wedging, or if the tip is not in zone 3, or if there's a transducer error due to incorrect zeroing or positioning or gain setting on the transducer. If it is truly elevated, then one must go through this differential diagnosis of the causes of elevated left atrial pressure, including mitral valve disease and increased end diastolic volume, decreased myocardial compliance, or increased pericardial pressure. In addition, one can obtain some clinically relevant information by examining the pulmonary artery occlusion pressure waveform. Remember, this is similar to the central venous waves and the left atrial pressure, with the A waves, the C waves, and the V waves. But of particular importance to us are the so-called pathologic V waves, which are higher and occur earlier than the physiologic V waves, because they are a sign of some kind of abnormality, most commonly mitral regurgitation, but also of volume overload and myocardial ischemia. There is also a phenomenon called pseudo V waves, which are also known as Canon A waves, which are due to the additive effect of simultaneous contraction of the atrium and ventricle, leading to a summation of an A wave and a C wave. This is encountered with AV dissociation, nodal rhythms, complete heart block, and use of ventricular pacemakers. This shows an example of these Canon A waves in the central venous pressure. On the first two columns, we show the ECG and the central venous pressure while the patient's in normal sinus rhythm, and the bottom two waves show when the patient is in nodal rhythm, and note the tall spiking Canon A waves when the patient is in nodal rhythm. Another importance of pathologic V waves is it could make you think that the catheter is not wedged. In other words, as you inflate the balloon, you may still see waves, and you could think that that is because the catheter isn't adequately wedged, which could induce you to advance the catheter further or inflate the balloon more excessively, when in fact these might be V waves due to regurgitation, and you could cause rupture of the pulmonary artery. So when you encounter these waves, you must try to determine whether this is because the catheter is inadequately wedged or because they represent mitral regurgitation. On this slide, I summarize some of the clues that will help you identify whether this is an incompletely waved trace or true V waves. The most important clue is comparing the timing of these V waves with the timing of the peak of the pulmonary systolic pressure in the unwedged catheter. Notice that the peak of the systolic wave in the PA occurs with the T wave, whereas these pathologic V waves occur later. And thus you know that this is not an incompletely wedged catheter, but in fact these are V waves. This is an example in a patient. Here is before we wedged the catheter and after we wedged the catheter. And if you note that the peak of these waves after wedging the catheter occur considerably later than the peak of the systolic pressure in the unwedged catheter. Another parameter that we can get from a pulmonary artery catheter is cardiac output. Cardiac output is obviously a very important parameter for the reasons summarized on this slide. And additional reasons are listed on this slide. There are many ways to assess cardiac output. We usually do it clinically, but unfortunately even expert clinicians are wrong about 40 to 60% of the time, as summarized in these 5 studies. Thus, we need objective monitoring of cardiac output. The traditional investigational gold standard is the FIC, which is calculated from oxygen consumption divided by the arterial venous O2 content difference. Unfortunately, it is difficult to measure oxygen consumption in critically ill patients, and therefore it's not practical to use the FIC for routine critical care monitoring. Instead, there are a number of other options available to us, but the clinical gold standard is right heart thermodilution from the pulmonary artery catheter. So the cardiac output measured by pulmonary artery thermodilution is the clinical gold standard. But it's important to recognize that this accuracy is only about plus or minus 13%. However, it is the method against which all other methods are evaluated. However, remember that when we measure flow with the pulmonary artery thermodilution, we're actually measuring flow through the lung, right ventricular cardiac output, and not directly systemic cardiac output. When we use the PA thermodilution to measure systemic cardiac output, we're assuming that they are same, but this may not always be true in the presence of intracardiac shunt. Furthermore, it's invalid in the presence of severe tricuspid regurgitation and when a patient is on ECMO or has an RVAD in place. There are basically 2 methods used: the intermittent bolus technique, which was the original technique, or the continuous technique described by Yelderman, and is what we commonly use at the present time. Both techniques are erroneous in the presence of tricuspid regurg, cardiac shunts, RVADs, and when there is marked fluctuation in the pulmonary artery temperature, such as early after cardiopulmonary bypass, during rapid venous infusions, and perhaps with use of intermittent leg compression devices when you use the bolus technique. As I mentioned, we commonly use the continuous technique described by Yelderman, which is summarized on this slide. Note that this is time averaged over about 5 to 10 minutes, and therefore there's a delayed response in sudden changes in cardiac output. This shows the thermal element of the thermodilution catheter. Although some have questioned the validity of the continuous method, many studies have suggested that it is a fairly good representation of the standard bolus technique. So when we measure cardiac output, the question always is it normal? Well, normal is often quoted as somewhere between 5 and 7 liters per minute. However, it depends on many variables, including body size. And for this reason, we prefer to express cardiac output as cardiac index, which is cardiac output corrected for body surface area. And the normal cardiac index is between 2.5 and 4.5 liters per minute squared. However, even that number varies depending on patient's age, their stress state, anesthesia, and their temperature. The common denominator and principal determinant of cardiac output is oxygen consumption. So what is appropriate cardiac output? Because oxygen delivery is dependent not only on cardiac index but also arterial oxygen content, interpretation of what is an appropriate cardiac index depends on consideration of both oxygen demand and arterial oxygen content. Therefore, cardiac index should be higher than traditional normal in the presence of increased oxygen demand or decreased oxygen content, i.e. in anemia, but cardiac index may be acceptably lower than in the presence of decreased oxygen demand, such as during anesthesia and hypothermia. In summary, cardiac output must be interpreted in the light of what is appropriate for their physiologic state and their arterial oxygen content. Another unique parameter available with the pulmonary artery catheter is mixed venous oxygen. This represents the average amount of oxygen in the blood returning from the body, and the best place to measure this is in the pulmonary artery. Although people use superior vena cava and right ventricle and right atrium, but none of the latter are as accurate as the pulmonary artery. There are many ways of expressing mixed venous oxygen, but the most common method is venous saturation, which is the most common method is hemoglobin saturation, which is normally between 70 and 80%. Remember that saturation must be measured by a multi-wavelength oximeter. Venous saturation must be measured by a multi-wavelength oximeter because of the effect of changes in P50, as discussed in the next 2 slides. So why are we interested in mixed venous oxygen? Mainly because it tells us about the balance of oxygen supply versus demand. This relationship is illustrated on this slide. Under normal circumstances, the body is designed to match oxygen consumption with oxygen delivery, so that mixed venous oxygen remains stable at about 75%. When oxygen consumption increases, normally oxygen delivery increases, conversely, and keeps venous saturation 75, while when oxygen consumption decreases, oxygen delivery normally decreases and venous saturation stays 75%. Therefore, if mixed venous oxygen is low, it suggests that supply is not meeting demand. This is usually due to inadequate supply, but occasionally can be due to excessive demand. Therefore, a low mixed venous oxygen is always abnormal and demands your attention. Unfortunately, a normal or high mixed venous oxygen does not always imply that all is okay for the reasons that are summarized on this slide. There are also continuous venous saturation catheters. These are convenient but not essential. remember they use two wavelengths and therefore can be influenced by both hemoglobin saturation and the correction by hematocrit, and also by the presence of abnormal hemoglobins. The mixed venous oxygen also has other applications besides telling us about the balance of oxygen supply and demand, as summarized on this slide. Most importantly, it can allow us to derive important information about the size of shunts, about oxygen delivery and oxygen consumption. Besides the primary variables, the pulmonary artery catheter provides us with additional derived variables as summarized on this slide. Remember, as I've said, cardiac index is derived by dividing cardiac output by body surface area, and the normal is indicated here. Another important parameter is stroke volume. The stroke volume is a overlooked and underutilized hemodynamic parameter, because if cardiac output or index is normal but heart rate is elevated, one may overlook the fact that in fact stroke volume is reduced. This, of course, is abnormal and deserves your attention. Another important variable that is only available when you have a pulmonary artery catheter that provides you with both venous pressures and blood flow is resistance. The general formula is listed here, and for both systemic vasoresistance and pulmonary vasoresistance. The factor of 80 is to change the units from millimeters of mercury per liter per minute, which are also called Wood's units, to the System International units. In addition, it is my opinion that systemic vasoresistance should be indexed to body surface area. This is because pressures don't vary much with body size, but blood flow does. If you don't index vasoresistance, then large people will have falsely low resistances, and small people will have falsely high resistances. So the way to calculate resistance index is to use cardiac index in the denominator instead of cardiac output. The normal values for resistance index are listed at the bottom of this slide. Finally, there are a number of oxygen-derived variables that you can get from a pulmonary artery catheter, and the most important is oxygen delivery index. After all, this is the primary function of the cardiorespiratory system, is to supply adequate oxygen to the body. And this is calculated as the product of cardiac index times arterial oxygen content, and the normal is about 700 milliliters per minute per meter squared. The importance of this is as oxygen delivery goes down, when it reaches a critical level of about 300 milliliters per minute per meter squared, you develop systemic acidosis and organ dysfunction. Other oxygen-derived variables are summarized on this slide. So what are the indications for using a pulmonary artery catheter? When pulmonary artery catheters were introduced in the 1970s, they quickly began to be used in most patients who had significant cardiovascular disease or acute pulmonary or renal insufficiency or shock, especially if they were elderly, both in the operating room and in ICUs. And for many reasons, it was logical to believe that all of this physiologic information would help our patients, and so we were confident that we were helping. However, in the mid-80s, some observational studies began to challenge these opinions. These culminated in an observational study by Connors, who found using propensity matching that pulmonary artery catheters were associated with worse outcome. This led to the conduct of a number of randomized controlled trials in the first decade of this century. These trials found the good news that their use was not associated with increased mortality, but unfortunately they could not document that they reduced mortality. These major studies are summarized here, and you can see no difference in 28-day mortality between the control group and the pulmonary artery catheter. Pulmonary artery catheters neither increased nor decreased mortality in these patients. Thus, in many critically ill patients, the use of PA catheters seemed to have neither positive or negative effect on outcome. But in good hands, the incidence of serious complications is low. That is illustrated on this summary of the incidence of complications in these randomized controlled trials. And you see that there were no deaths among these over 2,500 patients who received PA catheters in these trials, and the incidence of other complications were quite low. Of course, arterial puncture is not due to the PA catheter itself, but due to placing a central line. This low incidence of complications indicates what can be achieved, but probably represent the best that can be expected because the clinicians had much experience using PA catheters and they knew they were under the microscope. As a consequence of these randomized controlled trials, there has been a marked reduction in the use of pulmonary artery catheters, as illustrated in these two studies. However, there are important limitations to these randomized controlled trials. First of all, survival may not be the only appropriate measure of benefit. Secondly, in several of these studies, only parts of populations of critically ill patients were included. For instance, in the ARSNet study, only 10% of the patients who had ARDS were randomized. Therefore, it's conceivable that patients who might have benefited were excluded from the study. Thirdly, there is often considerable delay between the onset of the critical illness and the incidence and the initiation of pulmonary artery catheter. In the ARSNet study, it was more than 24 hours. And we know that in critically ill patients, delays of therapy compromise outcome. Thus, earlier use of the pulmonary artery catheter to guide therapy might have led to more favorable outcomes. Furthermore, there may be subgroups of patients in whom use of pulmonary artery catheters have favorable effect on outcome. And finally, the incorporation of clear-cut therapies and goals, which often were not used in these studies, may improve outcome. In summary, this review of the Cochrane database suggested that there is mounting evidence that preemptive strategy of hemodynamic monitoring coupled with therapy will improve outcome. Use of the monitor alone will not improve outcome, but using that data to guide therapy is likely to improve outcome. Finally, the absence of evidence is not evidence of absence. Just because we haven't proven its benefit in some patients doesn't mean it isn't beneficial in other patients. Furthermore, there is little evidence, if any, that any of our monitors that we use in caring for critically ill patients improve outcome, and this was demonstrated in this systematic review. Vincent has summarized the reasons why pulmonary artery catheters use has decreased, and they mention the bad reasons, less bad reasons, and good reasons. But as I mentioned, as a consequence of these randomized controlled trials, there has been a trend to stop using the pulmonary artery catheters and instead to use less invasive monitors such as central venous oximetry and less invasive methods of measuring cardiac output. However, If we believe that the use of the most accurate data that we can get, in other words, that from a pulmonary artery catheter, doesn't improve outcome, why would we expect the use of less precise data from these less invasive monitors will improve outcome? This seems to be an error in logic. Thus, despite the trend away from using pulmonary artery catheters, I believe pulmonary artery catheters should remain in our armamentarium of monitoring during anesthesia and intensive care, because it can provide unique information in a rapid and reliable and real-time format, often continuously, with very little activity on the part of the clinician. This information can assist with the diagnosis and help explain abnormalities. It can guide and evaluate hemodynamic therapy, and with care, its use is fairly safe. As I've mentioned earlier, this is a list of the information that we can get from a pulmonary artery catheter and how it can help us manage patients. Finally, pulmonary artery catheters can assist with fluid management. While static fluid pressure are poor guides to filling and especially fluid responsiveness, the data provided from a pulmonary artery catheter can be invaluable in managing fluid therapy. It can help determine if there is a problem that might respond to fluid. It can identify the pathophysiology of the hemodynamic abnormality, and most importantly, it can assess the response to volume loading. These three features are summarized on the next 3 slides. It can help determine if there is a problem. It can help identify the pathophysiology of the hemodynamic abnormality. And most importantly, it can help assess the response to volume loading. Is it helping the patient or is it hurting the patient? Furthermore, others agree that the use of pulmonary artery catheters should remain in our armamentarium, as summarized in the next few slides. Let me address the arguments against using pulmonary artery catheters. They are mainly 3: complications, failure to demonstrate benefit, and availability of less invasive methods. I have already addressed the issue of complications. Although PA catheters can be associated with many different complications and even death, when used carefully and properly, the incidence of serious complications is very low. And I believe the risk-benefit ratio for the management of critically ill patients is acceptable. It is noteworthy that the risk of rupture of the pulmonary artery catheter, of the pulmonary artery associated with the pulmonary artery catheter, which is the most dreaded complication, is not too different from the risk of esophageal perforation associated with use of TEE, which is commonly recommended. Furthermore, the most common and probably most important complications of use of the PA catheter are not the catheter itself, but the risk of obtaining erroneous information or misinterpreting the information and inappropriate therapy based on these errors. This is not due to the catheter, and these deficiencies are shared by all monitors and can be minimized by proper education and knowledge. The second criticism is that we have failed to demonstrate benefit, but I have just reviewed these data and discussed their limitations and tried to explain why these data do not justify discarding the use of pulmonary artery catheters. Finally, opponents of pulmonary artery catheters indicate the availability of less invasive methods of obtaining the same hemodynamic information. There are less invasive methods, as summarized on this slide, but none are as accurate as the pulmonary artery catheter, nor as easily or repeatedly or continuously available. And at the end of this PowerPoint, you can see supporting evidence supporting this assertion on my part. A final argument is that since we use the TEE in cardiac surgery and anesthesia, we don't need the pulmonary artery catheter. In my opinion and others, the use of pulmonary artery catheter and TEE are complementary, not competitive. Each of these provide unique information not provided by the other, and thus are not substitutes for one another. The TEE provides unique information about function and filling of the ventricles and function of the valves, but it provides this information only intermittently. It is usually only available in the operating room. It can't readily or accurately assess pulmonary artery systolic pressure or cardiac output, nor can it measure mean pulmonary artery pressure or left atrial pressure. It can't assess mixed venous oxygen or oxygen delivery or extraction, and it is quite difficult to learn and requires much experience. On the other hand, the pulmonary artery catheter provides unique information, often continuously, regarding the parameters that I've mentioned discussed previously. Furthermore, it is available in the postoperative units. On the other hand, it does not accurately assess filling of the ventricles nor their function or identify valvular abnormalities or detect myocardial ischemia. So both are needed. In summary, as I have said, the argument in favor of using the pulmonary artery catheter is it provides this information accurately and continuously that is not readily available by other monitors, and that it is relatively safe if used appropriately. Since no methods are as good as the pulmonary artery catheter for obtaining this information, I believe it should remain in our monitoring armamentarium. So I will now summarize my indications for use of the pulmonary artery catheter. The first is complex cases who have confusing pathophysiology or who are not responding to therapy. These include complex forms of shock, such as cardiogenic shock, septic shock, and shock following cardiac surgery. It should be used in the differential diagnosis of pulmonary edema or ARDS. It should be used in patients with severe heart disease who have obstetrical major surgery, critical illness, or trauma. It should be considered in severe trauma patients, in patients with the following characteristics. It should be used in the evaluation of pulmonary hypertension and right heart failure, and in many cardiac surgery cases. This is my list of indications for use in cardiac surgery, and they include LVAD implants, heart transplant, lung transplant, and patients undergoing cardiac cabbage and valve surgery if they have any of these characteristics. Others also recommend the use of pulmonary artery catheters as summarized in the next few slides. However, if one chooses to use a pulmonary artery catheter, I make the following recommendations. Reserve it for the sickest patients. Have well-defined goals, both diagnostic and therapeutic, and a rational reason as to why you think the pulmonary artery catheter might improve outcome. Initiate early. Make sure you get accurate data and interpret it appropriately and act on it rationally. And finally, remove it as soon as possible once you have achieved your goals. Most of the benefits will be realized within the first few hours or day, while the incidence of many of the major complications increase over time. Finally, one cannot use static filling pressure alone to assess intravascular volume status and predict fluid responsiveness, but as I've mentioned before, that doesn't mean the PA catheter isn't helpful in managing fluid therapy in these patients. On this slide, I've listed some of the absolute indications, contraindications, and some relative contraindications which have been mentioned by others. Finally, The pulmonary artery catheter is just one tool in our diagnostic and therapeutic armamentarium. One must integrate the information provided with all other data and be quick to add echocardiography. But those of us who advocate continued use of pulmonary artery catheter may be in the minority. This editorial by Rubenfeld suggested that the days of pulmonary artery catheter were over, as did this commentary by Dr. Merrick. But I don't think it's wise to discard the PA catheter yet. Notice in this commentary that I just mentioned, they said that the story of the pulmonary artery catheter is a cautionary tale of the rapid adoption and slow evaluation of a monitoring device that, when used correctly, provides exquisite detail of physiologic information, but regrettably doesn't appear to benefit our patients. Shouldn't this teach us something about the adoption of other new monitoring modalities, such as central venous oxygen, non-invasive measurements of cardiac output, and echocardiography in critical care? Will future physicians be saying the same thing about these new monitoring modalities 20 years from now that naysayers are now saying about the pulmonary artery catheter? I have added a number of study questions for you on the next few slides. And that completes this presentation. Thank you.